Thank you, Mr. Chairman. I appreciate it. Thank the panel for their testimony today as well. Many conditions, especially within the rare disease community, lack treatment, and those that have a treatment do not have multiple therapies to choose from. Ms. Boyle and Dr. Pat, under the proposed rule, it seems like it would encourage physicians to prescribe cheaper or generic alternatives to benefit from a flat fee in the reimbursement payment. Do many of the Part B drugs have interchangeable alternatives?
Well, representing the Immune Deficiency Foundation, we have a number of conditions that only have one drug. There is not an alternative, whether it's a generic or non-generic. There's only one drug. And again, if this experiment reduces the ability of the physician to provide that drug, when you're talking rare diseases, there are very few physicians or hospitals around that have the ability to treat the patients. We experienced this with intravenous immunoglobulin back in 2005, 6, and 7 with the change in the MMA, and our patients were shifted from the physician office. Those that could find hospitals, and that was not always an easy thing to do, to infuse immunoglobulin, and where there are no generics, but there are a number of products, were lucky to find a site of care. Very often they had to change their product, and there were many who could not find a site of care and had to go without. There were the OIG and the ASPE reports did report on adverse events for these patients, sickness, hospitalizations, and there just aren't alternatives for the rare disease community. It's not just our patients, it's many other patients with rare disorders. So this is very frightening.
Thank you, Dr. Pat.
So I'll say in the oncology community, there are a few examples of treatment alternatives with equal efficacy and toxicity that have differences in cost. And in those scenarios, we think that utilization of the lower cost alternative would absolutely be appropriate. The problem is that these instances are few and far between. But in order to optimize the ability to give value-based prescribing, as I mentioned, the U.S. Oncology Network has pioneered value pathways. ASCO, the American Society of Clinical Oncology, has come out with a pathways policy statement. There are other pathways systems which utilize this, and the Community Oncology Alliance has come out with the Patient-Centered Oncology Medical Home, also trying to utilize a pathways system, really to facilitate appropriate utilization, because most of the time there are not alternatives that are equally efficacious and toxic that are of different costs, where a lower cost alternative is truly therapeutically interchangeable.
Thank you. Second part of the question, Ms. Boyle again and Dr. Pat. Under the proposed rule, one value-based tool is the use of reference pricing. This requires setting a standard payment rate for an entire group of drugs, usually using the most clinically effective drug in a group for therapeutically similar drugs. Can you do reference pricing when there are no alternative drugs available? And again, yes.
Well, for instance, in the immunoglobulin products, there are 13 of them. There have never been any trials, head-on trials comparing them. They all are approved by the FDA, but they're all very different. Some have high sugar content, some have high salt content that would be bad for patients with heart conditions or diabetes. They all have different formulations and patients react differently. Some are appropriate for subcutaneous infusion, which some patients need because they have poor venous access or they have other problems, adverse events to IV. Some patients cannot do subcutaneous. They're really not appropriate. So I don't know how you would put these together. Patients react differently, and when you look at the administration and talking precision medicine, and let's take the best product for the individual patient, this proposal runs counter to that.
Dr. Pat, briefly, because I want to ask another question.
And I'll say that we don't today have a way to do reference and value-based pricing in oncology, but we would love to partner with CMS to do that instead of having a policy just drop down to us.
Thank you very much. Mr. Chairman, I know I have 7 seconds, so more than likely I'll yield back if you'll give me a couple more Can I have a few more seconds to ask another question? Yes? Okay, thank you. Ms. Boyle and Dr. Pat, again, under the proposed rule, one of the value-based tools would have CMS pay more for effective treatments. Does CMS actually define what an effective treatment is? In the world of oncology or IG, where treatment is more personalized, as you said, is it wise to have an unelected Washington bureaucrat declare what is effective for all seniors? And I'll start with Ms. Boyle.
No, it's not. Essentially, we want our trained immunologists who are specialists in treating our patients to make these decisions. Again, this is important for any condition. Let's not take the decision away from the physician that works with the patient and what is the best treatment and the best outcome for that patient.
Thank you very much. Dr. Pat?
I completely agree. I think that this is not something that we want outside of our specialty's hands, outside of a physician's hands, and we would love to act in partnership with CMS to think about a better path forward to try to institute value-based mechanisms for implementation of cancer care.
Makes sense to me. Thank you very much.
Chair, thanks. The gentleman now recognized.